In the context of incurable diseases, there is a difference between the way you would treat a symptom from that in acute medicine or acute surgery. Let me take one example. Let us take, for example, the breathlessness of somebody with an advanced cancer in the lung, with an obstruction in a major airway somewhere lower down, so that even a tracheostomy cannot relieve that obstruction. If this person in the middle of the night comes to your emergency room breathing like this and totally unable to take in enough air, scared stiff, in panic, in suffering, what would you do? Would you immediately rush him to the intensive care unit? Wait a minute. Why are we talking about him? Let us talk about me as your patient at that point of time. Your intensive care unit, where I'll have to leave my family, is going to scare me. These could well be the last days of my life. They are important to me. I shall preach only those things that I practice. If it is a breathlessness from a flail chest, where the problem can be corrected and cured, by all means, the intensive care unit is necessary. Do put me on a ventilator and save my life in that situation. But here, if it is an advanced malignancy which is no longer amenable to definitive treatment, then what I would like is an assurance from you that you will care for me. More than anything else, your words, I see you are breathless. We are going to take care of you. That will give me a lot of relief. Meaningless words, everything is going to be okay, it's not going to reassure me. I know that everything is not going to be okay. But if instead you say, one of us is going to stay here to make sure that you get some relief, that will reassure me. I know you are too busy a doctor, you cannot stay with me all the time. That's why I said one of you. And I'm just saying how I would be relieved, because even that reassurance is going to ease my anxiety, my desire to draw a very deep breath, which will increase the negative pressure within my chest beyond the obstruction and actually cause more of the obstruction. So the easier I breathe, the slower I breathe, the better I'll be. But let us move on. Will you give me oxygen? Naturally, my family is all anxious and asking, doctor, are you not going to give him oxygen? Well, I'll tell you what I actually practice in that situation. I'll tell them, we are going to start oxygen. But I'll also tell them, we will see if that oxygen gives you some relief. If you do not like it in 10 minutes, we will take it away, because if it does not help you, it may actually make you feel a bit worse. This is the truth. Now remember that the answer is different between this situation and that of the person who has a correctable disease. Here, if my lung is full of say the tumor, your oxygen cannot be utilized by my lungs. And what's the point? And specifically at this situation, though I am an anesthetist who in a critical care unit is nervous if there is no pulse oximeter, in this context I will not connect a pulse oximeter, because once it is connected, everybody focuses on the pulse oximeter. Whether the saturation rises from 81 to 85 is of no consequence to me unless I feel better. Here the need is not to improve the saturation, it's actually to make me feel better. equilibration between the inspired oxygen and the blood takes only 7 minutes. In 10 minutes you know whether the oxygen saturation is increasing enough to make me feel better. If it is not making me feel better, actually the oxygen may be a nuisance. Once a pulse oximeter is connected, everybody's attention is on the pulse oximeter, on the oxygen saturation, not on the person. The saturation itself means little unless it has improved enough to give me relief. The acid test here is it giving me relief? You ask me after 10 minutes of starting the oxygen, you ask me whether I am feeling better. If I am, the oxygen is good for me. But if the oxygen really does not give me relief, it may actually be a nuisance in more than one way. If I am not getting relief, I may feel particularly hot under the mask. After some time it feels terrible, and it is dry gas which will dry up my respiratory tract, cause some burning and cause significant discomfort, and more than anything else, it's a barrier in communication. Already my voice is weak, I am unable to communicate with others, and then you have this thing that's impeding communication. Therefore, if it is not helping me to get relief, take the oxygen away. If you do not give the oxygen, the family may be disturbed, which is why right from the beginning you tell them that this is the reason we will try for 10 minutes, take it away if it does not help. Almost invariably the family understands this and is quite happy with it. There are exceptions, especially when there is a doctor in the family or a nurse in the family. They are unable to accept this concept and are often too centered on the oximeter. So sometimes some compromises are necessary. But let us come back to this patient. We have given him a realistic reassurance that we are going to take care of you. We have given the oxygen, we have started the oxygen trial. We already agreed that I would be treated in presence of my family as much as possible. If possible in a hospital room or ward rather than in the ICU. What medications would you consider? I would suggest two things which are usually most helpful in this situation. Strangely, as it may seem to many of you, one is morphine. Morphine, which we have been taught in pharmacology, is a medicine that can cause respiratory depression. But here, used in small doses, it actually improves the breathing. Not necessarily because the patient is in pain. It is possibly because of the effect of the small dose on the respiratory center slows the respiration down a little bit. And though it does not necessarily cause a lot of change in other parameters, it actually decreases the sensation of breathlessness, which is what matters really. The other medicine that's important is dexamethasone. Well, specifically dexamethasone is the commonest corticosteroid used, which reduces the edema around, say, the tumor. Any cancer causes edema around the tumor, and once you reduce the edema, even if the airway opens up by a millimeter, the difference in the air entry is enormous, isn't it? So this is something that we will achieve. But wait a minute, just giving these medicines is not enough. You have to look for other things. You have done the emergency measures. We must, as we examine the patient, look for correctable factors and correct them. Pain itself can worsen breathlessness. Is it pain? Is it infection? Is there a pleural effusion? that can be easily tapped to relieve the breathlessness? Is there significant bronchospasm which can be treated? So removal of these correctable factors is part of that management. So you see how management of breathlessness varies from the acute medical situation to palliative care, where here the focus is on comfort, on relieving the sensation.